today we'll be going over chapter 20, endocrine and hematologic emergencies. Endocrine and hematologic emergencies. All right, as usual, our National EMS Education Standard competencies. All of you can read, so I'll let you read this a little bit. So the most important thing is when we're talking about the awareness of diabetic emergencies can cause altered mental status. Just kind of keep it in your head that whenever I have a patient with altered mental status, but I don't see any obvious reason for the altered mental status, then automatically start thinking about diabetic patients. So making sure that in your part of your assessment, you get a CBG and so on and so forth, right? That CBG is very important for your altered patients. Somebody took control. All right. We'll also talk a little bit about sickle cell crisis and some clotting disorders. All right, introduction. So the human endocrine system, it directly or indirectly, it influences nearly every cell, an organ, and function of the body. So there's endocrine disorders that are often seen with multiple signs and symptoms. So we just have to make sure that whenever we're doing our thorough assessments, that we're notating or we're actually getting into these signs and symptoms. What did I do? All right. Sorry about that. I hit the wrong button. There we go. Now we're back on track. All right, so hematologic emergencies, they're very difficult to assess and treat in the pre-hospital setting. So pre-hospital being on the ambulance or out in the field or what have you, they're very difficult to treat and assess because we're having to depend on our knowledge and our critical thinking skills of some of these illnesses or some of these maladies that we are learning about, right? So you have to remember a lot more. Hey, I think I remember with sickle cell, then my patient presented with this. Hey, I know that, and you take into their demographic and everything. That's why it's important to gather that demographic information as well, because some of that may make a difference. All right, so the endocrine system is a communication system that controls functions inside the body. So endocrine glands, they secrete messenger hormones. So these hormones travel through the blood to the end organs, tissues, or cells that they affect. So with this, endocrine disorders are caused by an internal communication problem. All right. So it all boils down to communication, right? First thing to fail is communication in an emergency. So if a gland is not functioning normally, it may produce more hormone or what we call hypersecretion than what's actually needed, which can cause issues, or it can cause not enough hormone to be secreted, which we call hyposecretion, right? Just like with every other term that we use, hyper and hypo. So a gland may be functioning correctly also, but the receiving organ may not be responding appropriately. So you can see all this happens inside your body. So it's very difficult to assess with that. A lot of times underlying conditions come into play. And that's why you really have to peel back those layers of that onion, right? Is to find out those questions, ask those important questions to find out about past pertinent history, anything, any underlying conditions that this patient may have or that you may come upon, new conditions. All right, so glucose metabolism. So the brain needs two things to survive. All right, y'all all know this. We've talked about it ad nauseum. All right, so we need, or the brain needs, glucose and oxygen, right? All right, so insulin is necessary for glucose to enter the cells. All right, so insulin is used for glucose to enter the cells. It's like the doorway. It assists with the doorway, assists with the entry into the cells. So without insulin, the cells do not get fed. And so the insulin's like the spoon, all right, that goes into the mouth, right? All right, so the pancreas produces and stores two hormones, one of them being glucagon and the other one being insulin. Then you have what's called the islets of Langerhans. So those are found in a small portion of the pancreas. So within the islets are alpha and beta cells. The alpha cells produce glucagon. The beta cells produce insulin. Alpha cells, glucagon, beta cells, insulin. So the pancreas, it stores and secretes insulin and glucagon in response to the level of glucose in the blood. So depending on the level of glucose or sugar in the blood, it is going to respond to that level by secreting or storing the insulin and glucagon, keeping it stored or secreting it out. All right, so the pathophysiology of diabetes mellitus. So diabetes mellitus is a disorder of glucose metabolism, such that the body has an impaired ability to get glucose into the cells to be used for energy. All right, so without treatment, the blood glucose levels, they become too high, right? And in severe cases, they may cause life-threatening illness or coma and death, all right, which is not good. Death is usually not good. So if it's not managed well, it can have severe complications. Some of the complications from poor management of the diabetes mellitus is going to be like your blindness, cardiovascular disease, kidney failure, stuff like that. So there are three types of diabetes. Three types. You have diabetes mellitus type 1, you have diabetes mellitus type 2, and then you have pregnancy-induced gestational diabetes. All right? Or, pregnancy-induced gestational, like gestation as in pregnancy. All right, so the treatments for diabetes. So usually diabetes is treated with medications and injectable hormones that lower blood glucose levels. Now, diet and stuff like that can, also play a part as well. But when we're talking about patient care, we're talking about the medications, things like that, and the hormones. So if those are administered correctly or incorrectly, it can create a medical emergency if they're incorrect, right? It can create a medical emergency for the patient with diabetes that has the diabetes. So low blood glucose level, or what we call hypoglycemia, if it's unrecognized and untreated, it can be life-threatening. All right, as some of you may already know, the issues that come with that. So you got to be able to also recognize the signs and symptoms of high blood glucose level, or hyperglycemia. So hyperglycemia can result in coma or death also. So if treatment exceeds a patient's needs, it can cause a life-threatening state of hypoglycemia. Okay? So hyperglycemia and hypoglycemia can occur with both diabetes mellitus type 1 and type 2. So what's going to happen is you're going to encounter many patients that display the signs and symptoms of high and low blood glucose levels. So hyperglycemia and hypoglycemia can be very similar in their presentation. Okay, the way that they present themselves in our patients. So most all of your patients with these emergencies, they present with an altered mental status. So that should automatically prompt you to, hey, this could be diabetes. Okay, and then at that point you can do a blood glucose monitoring. You can use your blood glucose monitor and check the blood glucose and figure out which one it is, what the deal is. So it can often mimic an alcohol intoxication. Like your intoxicated patients, they often have abnormal glucose levels as well. All right, so hypoglycemia can develop if a person takes his or her medications but fails to eat enough food. If a person takes too much medication, excuse me, if they take too much medication, resulting in low blood glucose levels despite normal dietary intake. That's some things that can happen. So no matter what, though, all hypoglycemic patients require prompt treatment. All right, talking about diabetes mellitus type 1. So an autoimmune disorder in which the immune system produces antibodies against the pancreatic beta cells. Now we said beta cells do what? Anybody tell me? All right. So yes. So right up there. So it produces the antibodies against the pancreatic beta cells, like we said. Beta cells, we know beta cells, missing the pancreatic hormone insulin. Glucose cannot enter the cell without insulin. So if we don't have that, then we can't enter into it. All right, so the onset usually happens from early childhood, from the fourth decade of life. All right, or through the fourth decade of life. Through the fourth decade. So almost my age. So the immune system destroys the ability of the pancreas to produce insulin. So the patient must obtain insulin from an external source at that point. So patients with type 1 diabetes cannot survive without insulin. So many people with type 1 diabetes, they have an implanted insulin pump. So what it does, it continuously measures the glucose levels and it provides insulin and correction doses of insulin based on carbohydrate intake at meal times. All right, so this limits the number of times patients have to check their finger stick glucose levels. It can at times malfunction, and that's when diabetes emergencies can develop. So we always want to inquire in our patients if they have a insulin pump. All right, so type 1 diabetes. It's the most common metabolic disease of childhood. So a patient with new onset type 1 diabetes will have signs and symptoms related to eating and drinking. So signs and symptoms related to eating and drinking. So polyuria, using the restroom a lot, polydipsia, you see multiple times, polyphagia, weight loss, fatigue. All right, so on to what to look at on a monitor, right, when we're taking our CBGs. So normal blood glucose is between 80 to 120 mgdl. So we're looking on that monitor, 80 to 120. That is book normal. There are patients that can operate outside of those. There are patients that stay outside of those. It's what is normal for that patient, right? So you have to ask those questions. Is this normal for you, or what do you usually run somewhere in there? And your diabetic patients or ones that have been diagnosed, they'll know this. So when a patient's blood glucose level is above normal, according to these numbers, the kidney's filtration system becomes overwhelmed and glucose spills into the urine. So when glucose is unavailable to the cells, the body turns to burning fat at that time. So when the body burns fat rather than glucose, it produces acid waste called ketones. If anybody's ever been on the keto diet, they know what ketones are. So as ketone levels go up in the blood, they spill into the urine. So kidneys become saturated with glucose and ketones and cannot maintain acid-base balance in the body. So the patient breathes faster and deeper as the body attempts to reduce the acid level by releasing more carbon dioxide through the lungs. All right, so these are known as Kussmaul respirations. Okay. So in fat metabolism and ketone production, it can continue a life-threatening illness called diabetic ketoacidosis, or DKA, and that can develop. So DKA may present as generalized illness along with abdominal pain, body aches, nausea, vomiting, and altered mental status if it's severe. So if it's not recognized rapidly or treated, then DKA can result in death. So you have to obtain a glucose level with a finger stick using a lancet and a glucometer. Generally, anything higher than 400 is considered a DKA patient. Now, most of your CBG machines monitors only go up to 600 in the pre-hospital setting. In the hospital, they can go up way further. I think the highest I've ever had on a patient that I had brought to the hospital that was still awake, somewhat awake, was 1200. And I had to find that out at the hospital, not on mine. 600, it reads error. All right, so what we're going to do is we're going to go on a 10-minute break, and then I'm going to come back and I'm going to show y'all what Kussmaul respirations sound like. Okay? So let's go ahead and hit up 10 minutes. All right, and I'll see y'all in just a little bit. All right, let's see what we can find here for Kussmaul respirations. All right. So Kussmaul respirations is a little bit what they sound like. It just sounds like heavy breathing, looks like heavy breathing. But these patients are going to be altered. All right. See the heavy breathing?
Do you have any pain back here in your neck or anything? All right.
Y'all hear that?
Do you have any pain back here in your neck or anything? All right.
Right.
If growth is your goal, and I would guess that
It is not. Yeah, it's kind of hard to hear the breaths on it, but you can see how it looks. The breaths don't sound, they're just deep breaths. Deep breaths. They just yep. All right. So what we just went over was diabetes mellitus type 1. Now we will discuss diabetes mellitus type 2. So it's caused by resistance to the effects of the insulin at the cellular level. All right, so one thing to know that obesity predisposes patients to type 2 diabetes. So generally they have a larger body habitus. Generally, doesn't mean all of them, generally. So the pancreas produces more insulin to make up for the increased levels of blood glucose and dysfunction of the cellular insulin receptors. So insulin resistance can sometimes be improved by exercise and dietary modifications. So that insulin resistance, dietary, exercise modifications can be a big help. All right, there are some oral medications that can be used to treat type 2 diabetes. Some increase the secretion of insulin, and they pose a high risk of hypoglycemic reaction. So some of them also stimulate receptors for insulin. Others are going to decrease the effects of glucagon and decrease the release of glucose stored in the liver. There are also some injectable medications, and insulin are also used for type 2 diabetes. So moving on with diabetes type 2, it's often diagnosed at a yearly medical examination. And what it usually comes from is like complaints that's related to high blood glucose levels, and some of that can be included in like if you have recurrent infections, if you have changes in vision or numbness in the feet, then a lot of times it'll prompt some of those symptoms, signs and symptoms can prompt further look in and see if there is an instance that they have type 2 diabetes for these patients. So they'll run some more tests and then find that out. Robert, sorry, I didn't see your thing here. You said deep in, shallow out with a question mark. So it's deep in, deep out. I mean, it's just regular. It'll be regular. And it looks like somebody that's out of breath or something like that, kind of, but it's regular and it stays that way. And what they're trying to do is blow off they're trying to blow off that acid or get more of that, trying to create a buffer for itself, and it's not working. All right, symptomatic hyperglycemia. So this is going to occur when blood glucose levels are very high. All right, hyperglycemia, right? So the patient's in a state of altered mental status, so AMS. This is going to result it's going to result because of several combined problems with this patient. So in type 1 diabetes, it leads to ketoacidosis, or that DKA, right? With dehydration from excessive urination, so polyuria. All right, so that's what'll happen. And you'll give these patients fluids and everything, and that's where they'll just urinate. They'll constantly do that. In type 2 diabetes, this leads to a non-ketotic hyperosmolar state. All right, so it's a state of dehydration due to the discharge of fluids from all the body systems and eventually through the kidneys, leading to a fluid imbalance. So if an individual has hyperglycemia for a protracted length of time, the consequences of diabetes may be present. So some things to look out for are wounds that don't heal, numbness in the hands and feet, blindness, renal failure, gastric motility problems also. So when blood glucose levels are not controlled in diabetes mellitus type 2, a condition known as hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS for short, can develop. HHNS. Hyperosmolar hyperglycemic non-ketotic syndrome. HHNS. So the key signs and symptoms of HHNS are going to include hyperglycemia, altered mental status, drowsiness, lethargy. I consider all those AMS. Severe dehydration, thirst, dark urine, visual or sensory deficits, partial paralysis or muscle weakness, and then also seizures. Higher glucose levels in the blood cause the excretion of glucose in the urine. All right. So patients respond by increasing their fluid intake, which causes polyuria. All right, excessive urination, multiple urination, multiple. So in HHNS patients, the patient cannot drink enough fluid to keep up with the exceedingly high glucose levels in the blood. So the urine, it becomes dark and it becomes concentrated. So the patient may also, they can become unconscious, or they can have a seizure activity due to severe dehydration, because now they're going to have that imbalance in their body. All right, so on to symptomatic hypoglycemia, hypo on the lower end. So it's an acute emergency in which a patient's blood glucose level drops, and it must be corrected as quickly as possible. So it can occur in patients who inject insulin or use oral medications that stimulate the pancreas to produce more insulin. So when insulin levels remain high, the glucose is rapidly taken out of the blood. So if glucose levels fall, there may be an insufficient amount to supply the brain, right? So if glucose or oxygen aren't getting the brain, what's the brain going to do? It's going to be a drama queen, right? Brain's going to be a drama queen. It's going to start to shut down. It's going to start to get loopy, right? So you get into AMS, that altered mental status. You're going to become altered. You see there? So the mental status of the patient declines, or he or she can become aggressive, or they can display unusual behavior. I've had a 14-year-old kid that shoved me all over a football field house one evening. And I was just trying to get him to sit down so I could figure out what was going on, do a patient assessment, and get him fixed up. And he did not want to sit down. He was not happy about me trying to make him sit down. So I got shoved all over this little football field house for a little bit. All right, so unconsciousness and permanent brain damage can quickly follow if it's not treated correctly or treated in time. All right, so some common symptoms for low blood glucose, for that low blood glucose level to develop. The correct dose of insulin with a change in routine. Okay, so if you change your routine up, then you can actually create the problem, even with using the correct dose. But if you do it at a time that's not usual, it can cause issues. So more insulin than necessary, so an incorrect dose. Correct dose of insulin without the patient eating a sufficient amount. So let's say they take the dose and then they don't eat what they're supposed to eat, their routine, then that can cause it. And then correct dose of insulin, and the patient developed an acute illness right after that. All right, so on the slide here, you can see some signs and symptoms of hypoglycemia. So you have the normal to shallow or rapid respirations. You got pale, moist skin, and diaphoresis. Diaphoresis means what? Does anybody remember what diaphoresis means? Somebody's diaphoretic. What does that mean?
Sweating?
Sweaty. Yep, means they're sweaty. Yep, excessive sweat. Dizziness, headache, rapid pulse, and normal to low blood pressure. You're also going to have altered mental status, where they're aggressive, they're going to be confused, lethargic, or they'll have that unusual behavior that we talked about. We consider that altered mental status. They can be anxious or combative, which would also be altered. Seizure, fainting, or coma, those are all also altered mental statuses. Weakness on one side of the body, it can actually mimic looks kind of like what a stroke looks like. So the rapid changes in mental status can be a big issue. I'm in my wife's chair today. It is the squeakiest chair I've ever sat in. All right, so hypoglycemia is quickly reversed by giving that patient glucose. So whether it be oral glucose or D50 by ALS or what have you, or for some of your patients, you may have to give glucagon if need be. For your ALS, will have to give glucagon. So without glucose, the patient can sustain permanent brain damage from that, right? Because it's not getting the brain's not getting what is needed, oxygen, and they're not getting glucose. There's the glucose levels there. All right. This is what we're going to do. I'm not too keen on these patient assessments. So we're going to flip right through that. We're going to go to this. All right, awesome. All right, so the emergency medical care for your diabetic patients, because we're going to do our own patient assessment at the end anyway. So for your diabetic patients, one of the things is we giving oral glucose. There's a couple of packages of oral glucose there. All righty. Glucose 15, which means 15 grams, 15-gram dose. So there are 3 types of oral glucose. You have the rapidly dissolving gel, you got the large chewable tablets, and then you have the liquid formulation that it's almost like drinking, this squirt. All right, this is the gel here. So the only contraindications are if the patient doesn't have the ability to swallow. So your patients that are very altered, you don't want to give this to because you don't want them choking on it. And which also is going to be unconscious as well. If they're unconscious, then of course you're not going to give it. You're going to wear gloves before putting anything in the patient's mouth, right? And then you're going to follow local protocols for glucose administration, whatever your SOG state. After that, you're going to reassess your patient frequently. They should start, if they have hypoglycemia, they should start normalizing pretty quickly. And then you're going to provide transport to the next level of care. All right, so sometimes in the presentation of hypoglycemia, you can have seizures. So hypoglycemia is a possible cause of those seizures. Though brief seizures are not harmful, they may indicate a potentially life-threatening underlying condition as well. So they definitely need to get checked out. So the management is to ensure that the airway is clear, place the patient on his or her side if there's no possibility of any type of cervical spine trauma, right? We're not going to place anything in that patient's mouth. So things like bite sticks or oral airways, we're not going to place that in their mouth because we don't want to cause any issues, right? So we're going to have we're going to have our suctioning equipment ready in case the patient vomits. So in case there's emesis, we want to make sure our stuff is ready. If the patient is cyanotic, blue, right? Cyanotic, or appears to be breathing inadequately, we're going to provide oxygen or artificial ventilations if we need to. And then we're going to transport promptly with those patients. All right, our patients with altered mental status. So that is also a part of possible diabetic problems. So you can see that in hypoglycemia, and you can also see this in ketoacidosis. All right, so what we're going to do with this is use the mnemonic AEIOU tips. AEIOU tips. Can anybody tell me what that stands for? AEIOU tips. Okay. Okay. What else? So you have acidosis. These people are declining that. You have acidosis, you have alcohol, you have epilepsy, right? You have infection. Okay. You have overdose, you have uremia, you have trauma, you have tumor, insulin, psychosis, and stroke. Hey, tell you what, I'll be right back. All right. Just trying to find my glucometer. I couldn't find it. All right, so Robert's got a question. So are we as EMTs allowed to administer oral glucose or only assist patients? Are there any contraindications for oral glucose? So it depends on where you're at, what your SOG state in your particular organization. Yes, you are allowed to administer oral glucose. It comes in your in a lot of your packs. It'll come in your cases. You are allowed to administer it. But the contraindications, we read it off, was in the contraindications being somebody that's not conscious or not able to swallow. If they're not able to swallow or they're not conscious, they can't take oral glucose. So they got to be able to swallow. That's basically it for that. All right, starting off. So management of. So you want to ensure the airway is clear. You want to be prepared for these patients. You want to be prepared to provide artificial ventilations if need be. Also, you need to be prepared to suction if the patient vomits. So always have that ready. Also, be ready to provide that prompt transport. You also have to be aware of misdiagnosis of some neurologic dysfunction. So occasionally, patients with diabetic emergencies are often thought to be intoxicated. All right, so a lot of police officers now, they want you to go ahead and do a CBG check on these patients just in case. And a lot of times, and so some of these patients too, especially with your hyperglycemia, that DKA, it sets off these ketones. Ketones are you can smell the ketones. They're very sweet smelling, and they'll say it smells like fruity alcohol. Now I can't smell, so I can't smell it. But that I've had people walk, I've had people walk into a room, not walk to a room, wheel into a room, and me know that, or you can see it, but then there are people that can smell it as soon as they walk in. I know when I worked in the hospital, there were nurses that as soon as a patient that was in DKA walked in, or not walked in, but as soon as a patient was wheeled in that had DKA, they could smell that patient sitting at the nurse's station. They could smell it. I could never smell it because I can't smell. So that's my issue. So a lot of cops will misinterpret that as being some sort of fruity alcohol that this patient is drunk or that this suspect is drunk or what have you. And then they'll try to put them in jail, which, or they'll try to incarcerate them or detain them or what have you, which can, if left unmanaged, becomes a serious issue. So now they're starting to get a little more on that, and they will require them get a blood test or something like that, or get checked out by an EMT. All right, so continuing on misdiagnosis. So a diabetic patient, like I just talked about, if they're confined to the police, they can be at risk. So an emergency medical identification bracelet, necklace, or card, it can help to save those patients' life in those type of situations. So look for those things. So a CBG test that's performed at the scene, if the protocol will allow that, or at the emergency department, will identify that real problem if need be, if the protocols will allow. So you got to be alert for the potential for diabetes and alcoholism to coexist in a patient as well. So if you do have an alcoholic, a lot of times that has diabetes as well, is that they cannot properly, if you were to administer anything to them, it doesn't properly bind because of the alcohol, especially if they are alcoholics, long-term alcoholics, it may not properly bind. So then ALS has to come on scene, and they give thiamine, and then follow on with anything else, or thiamine and glucagon, and then they can treat those patients. All right, relationship to airway management. So they may not have a gag reflex, and vomit or tongue may obstruct the airway. So you got to carefully monitor the airway for these patients. You want to place the patient in the lateral recumbent position. Remember what that is, laying on the side, head supported, laying on their side. Okay. Make sure the suction is always ready and available. All right, here's some other hematologic emergencies. You got hematology. Hematology, anything ology is the study of, right? So hematology is the study of blood-related diseases. So three disorders that can create a pre-hospital emergency are going to be your sickle cell disease, hemophilia A, thrombophilia, and anemia. All right, so blood is made up of 4 components. 4. You have erythrocytes, you have leukocytes, you have platelets, and you have plasma. So each of the components of the blood serves a purpose in maintaining the body's homeostatic balance, that homeostasis. Right, so red blood cells, they contain hemoglobin, which carries oxygen to the tissues. White blood cells respond to infection and collect dead cells and provide for their correct disposal. And then platelets are going to be essential for clot formation. And you got plasma, which serves as the transport vector, right? It's the transportation medium for blood components, proteins, and minerals. So pathophysiology of sickle cell disease. So sickle cell disease is also called hemoglobin S disease. So it's an inherited blood disorder that affects RBCs, red blood cells. So it's found predominantly in people of African, Caribbean, and South American ancestry. African, Caribbean, and South American ancestry. So people with sickle cell disease, they have misshapen RBCs, or red blood cells. They're like sometimes the shape of a sickle, or they're shaped abnormally. So they have issues with blood bind or oxygen binding to the hemoglobin, all right, or to the red blood cells, right? So the dysfunction in the oxygen binding, and what that can do is it can cause also the sickle shapes or the abnormal shapes can cause unintentional clot formation. So those clots, just like with any other clots, they can result in blockage. That we call that a vaso-occlusive crisis. All right, any type of blockage that a clot causes, we call it a vaso-occlusive, because occlusive means blocking crisis. So vein, vessel, blocking crisis. Makes sense, right? So this can result in hypoxia. It can also result in substantial pain, and it can result in organ damage. All right, so sickled cells, they have a short lifespan. So that results in more cellular waste products in the bloodstream, and it contributes to sludging or clumping of the blood. So it's important for these patients to maintain hydration. So if they have an insufficient hydration, that can lead to increased clumping or that sludging that we talked about. So some complications associated with sickle cell disease are listed right here. So you have anemia, you have gallstones, you got jaundice, which is the yellow coloration, right? You got, and which is going to be an issue with spleen disorder, things like that. You also have splenic dysfunction. All right, continuing on, you'll also have this vascular occlusion with ischemia. Ischemia means damage, right, or injury. Some other stuff you'll have is acute chest syndrome, which is going to be the hypoxia, dyspnea, so trouble breathing, chest discomfort, and fever with these patients. This can also, you can have stroke, joint necrosis, which means death, joint death. You have pain crisis, which just means extreme pain for these patients, internal pain. You have acute and chronic organ dysfunction and failure. You have retinal hemorrhages in the eyes. You have increased risk of infection as well. So not good. None of that stuff's no good. There's a example of some sickle cell. The sickled cells, abnormal shape. This is what they're usually shaped like. Your RBCs and your sickle cell, they'll have abnormal shapes. Normal, abnormal. Normal, abnormal. So many of those complications are going to be very painful and potentially life-threatening for your patients. The patients is also more susceptible to infections during that time. All right, some clotting disorders, hemophilia. So hemophilia is rare. So it affects only about 20,000 Americans. So hemophilia A, it affects mostly males. So people with hemophilia A, they have a decreased ability to create a clot after an injury, which can be life-threatening. They'll bleed, bleed, and bleed, and bleed, and bleed, right? So patients with hemophilia A can be prescribed medications to replace the missing clotting factors, and it can release stored clotting factors, or it can prevent the breakdown of blood clots as well. So some common complications of hemophilia A, they're going to include things like you see here, your long-term joint problems that may require further on down the road joint replacement. You also have bleeding in the brain because of the weakened state, and then you also have thrombosis due to the treatment itself. So the treatment can actually cause clots, which can actually cause a thrombotic event. All right, thrombophilia. So this is going to be a disorder in the body's ability to maintain the smooth flow of blood through the venous and arterial systems. So the concentration of particular elements in the blood creates clogging or blockage issues. So it's going to create these clogs, thrombosis. It's going to create these thrombosis. So thrombophilia in itself, it's a general term that for many different other conditions as well. So it can on all of them result in blood clotting more easily than normal. Right? So it's like a hyper blood clotting, right? So it can be an inherited or a genetic disorder. Medications can be the factor of it. Patients with cancer this can actually happen. And then clots can spontaneously develop in the blood of a patient that are having these issues as well. All right, so some more clotting disorders. You got deep vein thrombosis, or what we call DVTs, deep vein thrombosis. So it's a common medical problem in sedentary patients or patients that are just laying around, that don't get up much, that don't move much. And patients who have had recent injuries or surgery, you can get deep vein thrombosis as well near those injury or surgery sites. So some of the methods that we do have to prevent this blood clot from forming, you got blood thinning medications that can be taken. You got compression stockings, and then you also have mechanical devices to keep that from happening as well. So some other risk factors with this, if they've had a recent history of joint replacement and then they complain of leg swelling, all right, that could be DVTs. And that DVT can move. Once it moves, it can become a problem, become an embolus, right? And then anybody that's sedentary for long periods of time can have this issue too. Some treatments for DVTs are going to be your anticoagulation therapy. So something that's going to prevent coagulation. And then oral medications that are typically administered for at least 3 months after diagnosis of a DVT. So a clot from a DVT, it can travel from the patient's lower extremity to the lung, which can cause that pulmonary embolus, like I talked about earlier. All right, so your emergency care for hematologic disorders. So emergency care is mainly going to be supportive and symptomatic. So for patients with inadequate breathing or altered mental status, you're going to make sure that you administer that high flow, 12 to 15 liters a minute via the non-rebreathing mask. You'll want to place those patients in a position of comfort and transport rapidly to the hospital. Right. All right, so let's take a 10-minute break before we jump into our patient assessment of the night. All right, 10 minutes. I'll see y'all in 10 minutes. Starting now. All right. And we're back. All right. So, who wants to take this one tonight? Who wants to rip this one up? Y'all did a fantastic job Tuesday. Let's keep up the good work. So, who wants to step up for this one? Anybody? Am I going to have to call somebody? You don't have a mic. I would prefer somebody with a mic so we can flow through it like a normal assessment, if that's okay, Robert. Thank you for being understanding, sir. All right, so who with a mic wants to jump in here and do it? Somebody preferably that has not done it before. Remember, you got the slides. The slides are going to be right there with you. You just got to ask the questions. Follow the slides. For right now, we're going to be using the slides. When we get into the trauma stuff, we may use the slides once or twice, but after that, I'm going to let y'all depend on y'all's memory and everything else to get us through, right? So you got the slides to help you out throughout the way. The only thing you got to do is make sure you look at the slide and then you ask the questions from the slide using the slide, right? So come on, who wants to step up? Anybody? Come on, y'all are doing so good. All right, so I'm gonna have to pick somebody. How about Caleb Snyder? You know we're gonna sit here until somebody picks it up. So who's it gonna be? Y'all got phones. You could call in. You could call in from your phone. Let's see here. Hold on, I'm looking it up. There's the stuff for it. If anybody wants to call in and do it.
Hey, can you hear me, Chase?
Yep, sure can. Awesome. All right. You ready?
Yeah, I think I'm ready for this.
I know you're ready. I know you're ready. All right. So you're a patient. So you get called in for a 40-year-old male, possible diabetic emergency. All right. Go for it.
Okay, Rescue 14 on the way to a 40-year-old male with a possible diabetic emergency. As I'm going to the scene, I'm getting BSI. As I arrive to the scene, I'm gonna make sure scene's safe.
Okay. All right. So you said you were putting on your gloves, your safety glasses. You get to the scene and you're inside the patient's kitchen. There's no hazards.
Next, I'm gonna determine the nature of illness, which from the
All
call
right.
of a diabetic emergency.
Okay. So when you get in there, you see on this patient, on this 40-year-old male patient, rapid breathing, fruity breath odor, and an altered mental status indicative of a DKA. Okay.
And then, so I'm assuming he's the only patient at the time.
He is the only patient.
And as of now, I'm going to request additional assistance from ALS, but it may not be needed.
Okay. Awesome.
And
All
then
right.
I'm going to consider the stabilization of the spine, but as of right now, I don't think it's necessary. Is he sitting
Nope.
in the chair? Is he?
We'll just say he's sitting there. He didn't no need for C-spine, no traumatic anything. All right.
So next, I'm going to say, get my general impression of the patient.
Yep. So he's sitting in a chair. He appears lethargic and in a little bit of distress. So when you walk up to him, how would you walk up to him first? Let's go through the YAV and how would that work?
Was the general impression? I'm going to say he's sick. I'm going to
Yep.
say, I'm going to walk in. I'm going to say, hello, my name is Caleb. I'm going to be your EMT today. What seems
As
to be the
soon as you
problem?
start as soon as you start talking to him, he looks up at you. He didn't look at you as you came into the room, but when you started talking to him, he looked up at you, but he appears a little disoriented.
Okay, so I'm going to say he's got a verbal response on his level of consciousness.
Yep. Yep. Um. So he was verbal. So I'm gonna give you this for your Glasgow Coma Scale. Let's see if you can get your GCS. You're doing awesome so far. So remember, it's eyes, verbal, and motor response for GCS. All right. So he opens his eyes in response to your voice. His verbal, he's confused, and then his motor response, he obeys commands in motor response. So what do you think his GCS would be? Opens his eyes in response to voice, confused verbal, and obeys commands.
I haven't studied much on the Glasgow, but I'm going to say an 11 or a 12.
Okay, so close. So eye opening, opens eyes to response to voice would be a 3. And then for verbal, his confused would be a 4. And then his motor response, since he obeys commands, would be a 6. So he's 13. He's a 13. Okay. All right. So from there, we know that. So now, so far, he's lethargic, he's got rapid breathing, and he's got a fruity breath odor, right? All right. So what's next?
I'm going to determine the chief complaint or apparent life threat,
Okay.
which as of right now is a diabetic emergency.
Mm-hmm. Yep.
No
Okay.
apparent life threats as of right now.
No apparent life threats, no bleeding, no major bleeding, anything like that. Uh, you can continue on to your ABCs.
And next, I'm going to assess the airway. Is the airway patent?
Airway is patent.
And then next, I'll assess the breathing, which you said is
So his breath sounds reveal like it's rapid breathing. His breathing it's rapid and deep. So what type of breathing would we call that?
the uh, is it Kausman?
Kussmaul. So
Kussmaul?
on you're at a fire department, right?
Yes, sir.
All right, so that little device, whenever you crank your fire truck off and it kicks off the air off the truck or the electrical off the truck, what's that fixture called?
The air brake?
No, do y'all have it hooked into like an airline? Your truck hooked into an airline or electric line
Uh,
to keep the battery up?
with just an extension cord to the batteries, but we don't have an airline hooked up.
Okay, so if you got the extension cord hooked up to it, does it kick it off for you whenever you crank up the truck?
Yes.
That's called a Kussmaul. So it's the same device. It's the same thing. Kussmaul respiration is even spelled the same, but that's how I always remember it. Is my airline. So Kussmaul respirations, and when it comes off, it blows out the air, and that's how I remember Kussmaul respirations because it blows out the air. So I just remember my Kussmaul ejector on my fire truck. So it's Kussmaul breathing. That's just one way. You know, firemen have weird ways of doing things. But Kussmaul breathing. All right. So you have the airway is patent. Breath sounds are rapid and breathing. His breathing's rapid and deep, but he's having those Kussmaul respirations. So what do you think you should do for this patient since he is having trouble breathing? What do you think you should do?
We're gonna put him on a BVM. No, not a BVM, a non-rebreather at 12 to 15 liters per minute.
Awesome. All right, keep on trucking.
And next, we're gonna assess the circulation. I'm gonna look at the skin color, temperature, and condition, and check the pulse.
So circulation, no active bleeding at this time. Upon your pulse check, you have rapid and weak pulse. Your assessment of the skin is warm and dry at this time. All right. What's next?
We're going to identify the patient priority in treatment. Transport decision, which I would say was a high priority.
Okay. All right. So he's a high priority patient and transport, if you can, with ALS support, right?
Yes.
All right.
And
awesome.
The next step would be history taken.
Right.
And since there's no pain involved, there's no need for the OPQRST, right?
You can. There's still some answers you can get from it. Usually I use it for pain, but you can get it from your sample history as well. It's up to you.
Okay, well we'll go ahead and go through it.
Okay.
So when did you start having these breathing problems?
So I started feeling like this around yesterday. I started feeling bad around yesterday.
And
remember, provocation provokes. Does anything make it better or worse? Oh, am I breaking up?
No, you're fine.
No. Sorry, I got I'm on a MacBook, so at a certain time, I'm guessing today at 8:15, my little paper that I'm reading turned from white to black, and so I thought something was wrong on my screen.
I got provocation confused with radiation for a second.
Yep. So provocation, yeah, anything make it better or worse? Nothing specific. All right. What's
Okay.
next?
And quality is next.
How do we ask that question?
What kind of pain are you experiencing right now?
Can you describe to me what's going on? Right? Since there's no pain, you'd have to kind of modify that question. Can you describe to me what's going on right now? And describe to me your signs and symptoms. And so I would tell you, I'm constantly tired, I'm constantly fatigued, and I'm thirsty. I'm thirsty. And then since
Okay.
there's no severity, there's no scale of 1 to 10 because there's really no pain,
Yeah.
then I'm gonna say it's been getting worse as it goes along. This may be a family member talking to you too. It's like, so what, has it gotten any worse? Is it getting any, what's been the progress of it? And they'll say it's been getting worse. And so from there you can go to sorry, I had a brain disablement there for a minute. So time, consistent since yesterday, and then if you have any clarifying questions, you would ask what if you wanted to clarify it up because this patient is obviously fruity smell, everything is going on. I'm thinking DKA, right? So I know
Yeah.
that this patient should be on some type of medication for it. So I'm going to ask for clarifying questions. I'm going to ask, hey, have you taken your insulin today? Um, and that patient would tell you at that time, I missed my dose yesterday. All right,
Okay.
keep on,
Could I
keep
also
on
ask
trucking.
if you've been urinating a lot?
I was, and I hadn't been. Now I do when I can, and it's very dark colored.
Okay. And do you have any well, the signs and symptoms would be next, and would you have dark urine? Was urinating frequently, and you have been thirsty since yesterday?
Yep, been thirsty and lethargic and all the other stuff.
Do you have any allergies?
No, I don't have any known allergies, not that I know of.
Are you on any type of medication? Are you taking any herbal supplements?
Insulin. I missed my dose.
And have you had any past experiences with any diabetic?
Yeah, so I was diagnosed with type 1 diabetes about 10 years ago.
Okay, and what was the last thing you had to eat or drink?
Water a few hours ago. I've been super thirsty, so I've been drinking a lot of water.
And what were you doing right up to when this happened? Were you doing anything stressful or out of the ordinary?
Now, I wouldn't do anything stressful. I just missed my insulin dose, and then I got really thirsty and urinated a lot.
And then from there, we would need to go to the secondary assessment.
Right? Would you do detailed or focused?
We're going to do a detailed.
All right. So a detailed would be head to toe, right? That'd be like your trauma
Or
patients.
focused. Sorry.
Okay. No problem. All right. And what do you want to focus on?
The psychological,
Okay. So
possibly neurological, and cardiovascular.
yeah, so cardiovascular, he's got a rapid weak pulse, like we talked about. Neurological, he's altered, very lethargic, or acting like he's sleepy. Uh, his skin's warm, dry. His skin is warm and dry right now. Pulmonary, he's got the Kussmaul respirations, right? Uh, Musculoskeletal, we ain't worried about anything there. GI, he's very thirsty, increased urination, and he's anxious also. All right.
And then after that, we would want to do the vital signs. So
Right.
first, I would check your blood pressure,
All right, so blood pressure is 100/60.
and then your pulse.
It's 110 in regular.
Respiratory rate you said was rapid and deep.
Yep, it's rapid and deep at 24 breaths a minute. So we would just label that in our documentation, Kussmaul respirations.
And
Kussmaul.
and then next, I would want to check your glucose.
450.
And after that, I would state my field impression. I would say that you were either DKG, possible DKG, or hyperglycemic.
DKA.
DK,
Yep.
DKA.
Yep, your impression you're saying is possible diabetic ketoacidosis or DKA. Due to what? What was the event that probably caused it?
Missing insulin.
Yep. All right. All right. So what would you like to do? What type of interventions? You always have to verbalize those proper interventions and treatment when you're doing it.
So the only thing we could do would be giving oxygen on the.
Okay.
And since EMTs, we can't really give insulin, right?
Right.
And
Right.
no glucose since you're hyper.
Right. So this is what we would do. You would maintain the airway, of course. He's having an airway problem, so we add that in there. Maintain his airway, continue oxygen, and then when ALS shows up, they're going to do their thing. Which all we're going to do as ALS is administer fluids for this patient, and then we're going to prepare for rapid transport and continuous monitoring for this patient. All right.
And then
of course, treat for what? Easier to
treat for
prevent
shock.
than. Yep, there we go. Cover him up. Treat him for shock. All right. So I will give you. So you'll be needing a second set of vitals. How often? Or you'll
Every
need
5 minutes.
Every 5 minutes. All right. So your second set of vitals are blood pressure 105/65, pulse 100, respirations 22, SpO2 98% because you have him on oxygen. And your CBG that you took, haven't really got to give him anything yet, so it's still 450. We're just transporting. Cool. All right, so you'll do it every 5 minutes. All right, go ahead with you're at the hospital now. Nurse Karen says, yeah, what's up? I'm ready to get off shift, and you're holding me up. What's up?
Okay, Karen. So we got a call for a 40-year-old male, possible diabetic emergency. Upon arriving on scene, we found the patient in the kitchen. He seemed lethargic and distressed with regular breath. His breath smelled fruity. He had a verbal response. He looked at me when I started speaking to him. Airway was patent. He had Kussmaul respirations, breathing real rapid and deep. His skin was warm and dry. His pulse was rapid. He said he takes insulin. He missed his insulin shot today. He has a history of type 1 diabetes. He said he's been really thirsty. Upon arriving on scene and first vitals, we checked his blood pressure was at 100/60, pulse at 110, rapid. Respiratory rate was 24 breaths a minute. with Kussmaul respirations with a blood glucose level of 450. Suspected DKA. We maintained his airway. We gave him oxygen on a non-rebreather at 12 liters a minute, and we treated him for shock. And upon taking his second set of vitals, his blood pressure was at 105/65, a pulse of 100, and a respiratory rate of 22, with a SpO2 of 98%, and his glucose was still at 450.
Okay. Awesome. Awesome.
Where's the Gatorade
Thank
machine?
You. Yep. Give me your paper and I'll sign it. All right. Awesome. Thank you very much, Mr. Snyder.
Thank you.
All right. So that was very good. Very good. Very proud. That's awesome stuff. Y'all are getting better and better. Y'all are gonna blast this test out the water whenever y'all get ready to take it. All right, so let's start off with our review. Do a few questions here. So, type 1 diabetes is a condition in which hold your answers. Just hold them. All right, go ahead with them. A lot of B's, a lot of B's. All right. Answer is B. All right. Good job. All right, a 45-year-old man with type 1 diabetes is found unresponsive. Which of the following questions is most important to ask his wife? Just hold your answers. Hold your answers. All right, go ahead and answer them. Awesome. Awesome. All right, answer is A. Good job. We just went over it, right? We said one of the main reasons why is because he didn't take his insulin. Awesome. All right, question number 3. So a diabetic patient presents with a blood glucose level of 310 mg/dL and severe dehydration. The patient's dehydration is a result of what? Keep holding it. Keep holding it. All right, go ahead and answer. Okay. All right, let's take a look. Hey, awesome. Awesome possum. All right, which combination of factors would most likely cause a hypoglycemic crisis in a diabetic patient? All right, hold your answers. Hold them. All right, go for it. Okay. B. Awesome. B. Good job. Fantastic. All right, question number 5. So a 19-year-old diabetic male was found unresponsive on the couch by his roommate. After confirming that the patient is unresponsive, you should do what? Hold your answers. All right, go ahead and answer. All right. All right, let's take a look. B. So immediately after determining that a patient is unresponsive, your first action, remember this is one of those what would you do first things. Your first action would be to manually open his or her airway via the head tilt chin lift or the jaw thrust, whichever one you deem to be appropriate. Use a suction as needed to clear secretions from the patient's mouth. After manually opening the airway and ensuring it's clear of obstructions, insert a nasal airway adjunct and then assess the patient's breathing. Ready? Awesome. All right. Wrapping it up. All right. So today, fantastic. So today was brought to you by the class code 1991. 1991. All right. So in 1991, the first emergency medicine journal, the Academic Emergency Medicine, is launched in 1991. So the launch of the first emergency medical journal or medicine journal, the Academic Emergency Medicine, it provided a dedicated platform for the dissemination of research. So this also was dissemination of scholarly articles and advancements in the field of emergency medicine. So the Academic Emergency Medicine and subsequent journals afterwards have contributed to the growth of evidence-based practice and the sharing of knowledge among emergency medicine practitioners. So I always encourage our medics, our EMTs, what have you, is we'll give assignments to go look at journals. So articles and journals like things that have been tested and proven, right? So things that have been peer reviewed. So peer reviewed journals. And that's where you're going to get your most factual information. So we had the first launch of the Emergency Medical Journal, Emergency Medicine Journal in 1991, which is going to be what you're going to use today for a code. And you're going to do your attendance form with 1991. All right, so coming up this Saturday, August 26, 2023. So this Saturday, you got Chapter 19, GI and Urologic Emergencies and Platinum ED to finish. You also have Chapter 20, Endocrine and Hematologic Emergencies and Platinum ED. All right, so those are your two that are due this weekend. And then you have coming up next, you have Chapter 21, which is going to be allergies and anaphylaxis. So study up before Tuesday on allergy and anaphylaxis, Chapter 21. And then we'll come in here and we'll completely knock this out. All right, does anybody have any questions about today's class or today's lesson today? Okay, if not, then I'm going to stop recording right here. I really appreciate it. If you need to head on out, head on out. If you need to wait, wait. All right, so I'm going to stop recording. Thank y'all very much for stopping by tonight, and I'll see y'all on Tuesday.